Hello everyone, very warm welcome to all of you guys. Myself, Dr. Vaibhav Jain, and I wish you all very welcome, a very warm welcome to all of you. Now we are starting a new series over here at the Meduhub, and we will be covering the most important topics that can be asked in your FMG examination, upcoming examination. So we will be focusing on that. So we will be starting it off with the physiology. In the subsequent month, we will be doing all the classes, right? So these are my Instagram and Telegram. If you want to connect with me, let's start with the first thing. Before you can make a difference, you have to believe that you can, right? The most important thing that you can do at this point of time is to believe yourself. Okay, give me a quick confirmation. Hi Pooja, hi Gaurav, hi Pathus, right? A very warm welcome all of you guys. Today we will be covering the physiology, the most important things that can be asked in your examination. It's now only 60 days remaining for your examination, so we will be doing faster, a little faster. Yes, lecture will be recorded. Okay, so first question in front of you, we will be looking at the question. I will be making you understand how to understand the question, how to solve the question, and what are the different keywords you need to identify. This type of questions are being asked nowadays. Okay, so I would be integrating multiple subjects together. It is a high time. I hope you guys already have done your revision, right? So I'll be going a little bit faster. Good evening, Mohammed. Good evening. Yes, 58 days. The class will be approximately 2 hours long, but it will be covering most of the important things that can be asked in your examination. Just be with me till the end of the session and feel free about physiology, right? So I will be covering the most important things, right? Not just physiology, you will be looking at multiple subjects together, and it will be an integrated session. In the subsequent classes, I will be taking such more sessions as well, right? So the question number one says, try to answer this question. A 30-week pregnant lady with diabetes, the patient is having diabetes, she is a pregnant lady. Okay, she delivered a baby, and in that particular baby, what is the problem that we are having? Let me take the different color, right? Okay, so female is having diabetes, she is delivering the baby, and the newborn is having difficulty in breathing. Difficulty in breathing means the patient is having what? Dyspnea. Bilateral lung fields are involved on x-ray, right? Bilateral lung fields are involved, and on x-ray what is happening? X-ray is appearing white. So whenever you are looking at a white x-ray, that means white out type of lungs, you will be thinking in the terms of ARDS. That is a case of ARDS, acute respiratory distress syndrome. Okay, if air is present in the lungs, it should be looking black, but if your x-ray is looking white, that is going to be a respiratory distress syndrome. That is going to be a RDS. Okay, the diagnosis is, what is the diagnosis? The diagnosis is neonatal RDS. Decrease in which of the following phospholipid that is present in your cell membrane is responsible for this particular scenario? Yes, I'm getting an answer. Rahul, C. Okay, Anhar, C. Pooja, C. Yes. Okay, let me make the diagnosis. What is the diagnosis over here? This is a case of ARDS. This is a case of ARDS. What are the lipids? Let me make you understand the basics. What is a lipid? So lipid is a fatty acid plus alcohol. Whenever a fatty acid is binding with the alcohol, that is known as lipid. What is a fatty acid? That is a long chain of triglyceride. Okay, long chain of triglyceride is known as fatty acid. That is going to mix up with the alcohol. That is known as lipid. And when this type of lipid will be having phosphate together, this is becoming what? This is becoming phospholipid. This is becoming phospholipid. Yes, I will be giving the PDF, right? So this is a phospholipid that we are having, right? Now, what is the problem with the diabetic mother? Let me make you understand. It is a pediatric integration as well. So what is going to happen if the mother is a diabetic mother? You already know the baby will be a large baby. Let me make you understand what is going to happen. So what is going to happen? Mother is having what? Diabetes, and this type of diabetes is known as gestational diabetes mellitus. So what is going to happen in diabetes? What is going to happen? Yes, there will be increase in glucose. Increase in glucose, that glucose will be going to baby. More glucose will be going to baby. Baby will be having what? Increased glucose, that is hyperglycemia. So whenever the baby will be having more glucose, what will happen? Baby will be having beta cell. Beta cells in the pancreas will produce what? Increased levels of insulin. Because there is more glucose in the baby will be big. This thing is going to make the baby big, right? Because baby is getting more glucose, he will be big. Second thing, beta cells will be making more insulin, and this insulin is responsible for what? This insulin is going to decrease your surfactant. Remember, surfactant is going to decreased by insulin. What is surfactant? Surfactant is surface tension antagonist. This is a surface tension antagonist, right? So it is going to prevent the collapse of alveoli. You are having alveoli, so it is going to prevent the collapse of alveoli. Now what is going to happen? This insulin has a function. Two things will decrease the surfactant. First thing is your insulin, second thing is your smoking. Insulin and smoking, right? So what is going to happen in this particular baby? He will be having more insulin. He will be having more insulin, leading to what? Decrease in the production of surfactant. And second thing, if this baby will be having more insulin, and after the delivery, what is going to happen? The baby will not get adequate amount of glucose. Right now what is happening? When the baby is inside the mother, he will be getting glucose from the placenta, right? But after the delivery of the baby, he will not get adequate amount of glucose. So this baby will be presenting with hypoglycemia. You have to be very careful while treating this type of baby. So what you understand, if there is a GDM mother, you will be having a large for gestational age baby. The head of the baby, the body of the baby will be big. Second thing, this insulin is going to decrease the surfactant, right? Now what is our clinical implication over here? Let's try to understand. So what is the phospholipid that is going to make the surfactant? We are having certain phospholipids, right? We are having certain phospholipids. First one in the list we are having is phosphatidylserine. So what is the function of this phosphatidylserine? Remember, this phosphatidylserine is always present inside the cell. This phosphatidylserine is present inside the cell. Whenever this phosphatidylserine is going to come out, it is going to come out. That means this cell is undergoing apoptosis. This cell is undergoing apoptosis. Okay, so what is the simple understanding that you should be having? Whenever this phosphatidylserine will be coming out, outer exposure of phosphatidylserine will lead to what? Apoptosis. Will lead to what? Apoptosis. How you can visualize this apoptosis? Apoptosis is a programmed cell death. You can visualize with the help of a dye that is going to be annexin V. This is your previous year question. Annexin V is the dye we are going to put. If there is apoptosis going, what is going to happen? There will be phosphatidylserine will be coming out, and this is how we can identify whether this cell is undergoing apoptosis or not, right? So this cannot be the answer. It has nothing to do with the surfactant, sir. Okay, second case, this is your phosphatidyl inositol. Remember, this phosphatidyl inositol is going to responsible for a specific pathway that we have discussed, that is going to be your IP3 DAG system, and ultimately it will be making what? It will be making calcium. And remember, three things we have discussed in our classes. Now also I am telling you three things about calcium. First thing, whenever it is going to a vessel, it is going to cause vasoconstriction. Whenever it is going to a muscle, it is going to cause muscle contraction. Okay, and whenever it is going inside a cell, it will do what? Exocytosis. It will do exocytosis. That means whatever content is there in the cell, whatever vesicles are there, they will be coming out because of this calcium, right? So sir, phosphatidyl inositol cannot be the answer over here. So these two options are automatically ruled out. The third one we are having is phosphatidylcholine. What is the another name of this phosphatidylcholine, Biche? What is the another name of this phosphatidylcholine? This phosphatidylcholine has some another name. What is the another name of this phosphatidylcholine? Yes, try to answer. Please be interactive with me. And lastly, we are having this sphingomyelin. Remember, this sphingomyelin is also a phospholipid. All of them are what? Phospholipid. What I want to tell you, we are having a cell, and cell will be having cell membrane, and this membrane will be having three things. We are made up of what? We are made up of cells. We are having three things. We are having carbohydrates, we are having fats, we are having proteins, right? So cell will be having carbohydrate, fats and proteins. The question they have asked you, which is the major component of the cell membrane? The answer will be carbohydrate. You will be having more carbohydrate, right? So next thing, very good guys, I'm getting the answer right. That is going to be your phosphatidylcholine, is also known as lecithin. This is also known as lecithin, but remember in the exam they have not given both the term. They have given another term, that is going to be your dipalmitoyl phosphatidylcholine, dipalmitoyl phosphatidylcholine. They have given this particular term. This is your DPPC. This is nothing but your surfactant itself, right? That is nothing but your lecithin, right? So these are the different names for lecithin. Next one, we are having minor component of surfactant, that is going to be your sphingomyelin. Remember guys, definite one question from surfactant, be it your pediatrics, be it your medicine, be it your obs gynae, definitely you will be getting a question from this, right? So be thorough with this, right? We can understand this lecithin and sphingomyelin ratio, right? One more thing, this sphingomyelin has another function also. It will be having some protein, myelin basic proteins, and if there is mutation of this myelin basic protein, there will be a disease that is known as, anyone please try to answer, what is the disease that can happen if there is deficiency of this myelin basic protein? There will be damage of this myelin basic protein, is going to lead to a disease that is going to be, yes, that is going to be your multiple sclerosis, which is a demyelination disorder, This sphingomyelin is going to do myelination of the neurons as well, right? It is the minor component of the surfactant, but it is also going to do one more thing, that is going to be your myelination of the neurons, right? So this is these are the two important functions that we have to discuss, right? The function of surfactant will be simple. It is going to prevent the collapse of alveoli. It is going to prevent the collapse of alveoli. So we discussed about, you will be studying about hyaline membrane disease, you will be discussing about respiratory distress syndrome. So everything will be this, right? Next thing, we can check a ratio, you will be studying about that. We can check a lecithin sphingomyelin ratio. If this ratio is coming more than 2, that is going to indicate fetal lung maturity. That is going to indicate what? Fetal lung maturity. We can assess. We are having multiple method, you will be studying in obs gynae, but yes, you can also check for this particular ratio, right? For the treatment you will be giving what? Steroids. You will be giving steroids, and these are the steroids. They will be we are using in India, we are using two types of steroids. One is your dexamethasone, another one is your betamethasone. Dexamethasone and betamethasone. Dexa we will be giving 4 doses, okay, and beta we will be giving 2 doses, right? 24 mg we need to give within 48 hours. That is what you need to remember. Why we are giving these steroids? Because steroids has a specific side effect. What is that side effect that we are having, Vijay? The side effect will be, it will be causing hyperlipidemia. The steroids can cause hyperlipidemia, and remember, this is the hyperlipidemia that we want in our patient, right? Hyperlipidemia will lead to what? If there will be more lipid, there will be more production of phospholipid, there will be more production of lecithin, there will be more production of sphingomyelin, right? So this is how we are going to see, right? So now our answer will be, let's get back to the answer. What is the answer now we are having? Yes, so answer will be phosphatidylcholine, or you can also call it DPPC, dipalmitoyl phosphatidylcholine. You can also call it lecithin, right? So this is the case, right? Next, question number 2. A 31-year-old female patient is presented to OPD with the main problem that she is not able to conceive. What is the main problem that we are having over here? This particular female is not able to conceive despite trying multiple times. Along with the symptoms of headache, she is having another symptoms of headache, cough. For a long term, on X-ray examination, bronchial wall thickening is also noted. Okay, bronchial wall thickening is also noted. Along with that, patient is having what? Dextrocardia. This particular female is having dextrocardia. Which of the following can be responsible for this particular condition of the patient? Yes, it will be covering most of the things, don't worry about it. Just go be with me till the end of the session, and you will get to know so many things. Okay. So bronchial wall thickening is a feature of what? This is a feature you will be finding with the bronchiectasis. So first try to make the diagnosis. Guys, they are not asking simple direct questions from physiology. They are integrating multiple things. This type of question they are asking, they are integrating medicine. Ultimately, they will be asking for the physiology, right? So this is how you need to prepare, right? So this is the first thing. Bronchiectasis is there. Second thing, what you are finding, the main problem this female is having, infertility. This female is having the main problem, she is not able to conceive. What can be the reason? Let's try to rule out the option. Always remember, try to rule out the option, right? So first option is Desmin. What do you think Desmin is used for? Desmin, remember, Desmin is a marker for sarcoma. It is an intermediate filament. Like we are having keratin is a marker for carcinoma. Keratin is more present in the epithelial cell. Likewise, Desmin is a marker for sarcoma, which is a mesenchymal origin tumor. So whenever there is a mesenchymal origin tumor like osteosarcoma, what will happen? The levels of Desmin will be increased. We can check about that, right? Second option is your lamine. What is lamine? If there is mutation of this particular lamine, what is going to happen? Yes, I'm getting answers. Yes. So this is lamine. Lamine mutation will lead to a disease that is going to be your progeria. Pro means faster. Geria means geriatrics you study. That is going to be your aging. Right? You must have seen the movie Pa. Pa movie में क्या हुआ था? The Amitabh Bachchan को, he will be having that progeria. He will be having that progeria. Next one, this dystrophin. Dystrophin, remember this dystrophin is a very, very important thing, right? This dystrophin is present on chromosome number 1. This dystrophin is present on chromosome number 1, and this is a thing which is responsible for two important things. One is your, if there is mutation of this dystrophin, there can be two diseases that can happen. One is your DMD, second one is your BMD. What is this DMD? What is this BMD? Yes, DMD is Duchenne muscular dystrophy, BMD is Baker's muscular dystrophy, right? Duchenne muscular dystrophy, Duchenne muscular dystrophy, Duchenne muscular dystrophy, and Baker's muscular dystrophy, Baker's muscular dystrophy, Duchenne and Baker's. So what is the difference? Whenever there is complete loss of this dystrophin, this complete loss of dystrophin, it will lead to Duchenne muscular dystrophy. If there is a partial loss, it will lead to Baker's muscular dystrophy. Partial, you can remember, D will be full, B will be half, right? So that is going to be your partial thing, right? Duchenne patient will be dying earlier as compared to Baker's. Baker's will be living 10-15 years more, right? Next thing we are having is dynein. Remember, this dynein is responsible for two important things. One, it is responsible for reverse axonal transport. First thing, it is responsible for reverse axonal transport. What is the axon? What is the axon? Remember, we are having neurons, right? This is your cell body. This particular thing is known as axons, and then you will be having what? This is your synaptic vesicles. Here you will be having multiple dendrites, right? So this is the axon. So forward axonal transport is due to kinesin, and remember, this reverse axonal transport is due to dynein. This is due to dynein. This reverse axonal transport, let me give you example. Two examples, important one. One is your tetanus. One is your tetanus. Second one is your rabies. Both of them are 100% fatal disease. Both of them are vaccine preventable disease. Okay, so what are the two important things that you should be knowing? Both of them are important, right? Tetanus is due to Clostridium tetani, right? And rabies is due to which virus? Lissa virus. Lissa virus is a subfamily, right? So it is going to be the causative agent. Remember, so when we are having tetanus, what is going to happen? Those spores, tetanus clostridium is going to make spores. Those spores are present in the soil. So whenever the particular soil is going to come in contact with the blood, what will happen? The spores will get activated, and the bacteria that we are having, Clostridium tetani, is going to get activated, and now it is going to go retrograde. It is going to go on the backward direction. It will be going to your spinal cord. It will be going to your spinal cord. Remember, this one is going to go to your spinal cord. It is going to produce what? A specific posture that is known as opisthotonous posture. It is going to inhibit the inhibitory neurons. If inhibitory neurons are inhibited, that means what is going to happen? You will be having sustained contraction. Sustained contraction in the mouth, you will be having risus sardonius. You will be having what? Trismus, right? Medial pterygoid will be involved, right? Second thing, if it is going to your spinal cord, it is going to produce a specific posture that is known as opisthotonous posture. Very good, right? Next thing about this Lissa virus, this rabies, also you must have studied about a specific bodies that you are finding in the hippocampus. What is that body, right? I want your answer. What is that body that you will be finding in the hippocampus? So how this body is getting formed? Try to understand this Lissa virus. Rabies, you are having a dog bite on the leg, and what is going to happen? That virus will be entering into your leg and it will be going via reverse axonal transport. You understand? This is your reverse axonal transport. It will be going to your cell body. It will be traveling all the way up to the hippocampus, right? So it can go to the hippocampus. This is how this rabies is also going to travel with the uh, this particular pathway, right? So these are the two important reverse axonal transport that we are having. These are your rabies. Second one is your tetanus, right? So that is going to be two things. Remember, both of them we do not have exact treatment for both of them, and both of them are vaccine preventable. Please take care of this particular thing, right? Second thing, this dynin is also responsible for ciliary movement, ciliary motility or ciliary movement, right? Ciliary motility. What is the cilia? What is the cilia? Ciliary motility. Remember, cilia are always moving in a unidirectional movement. They are going to do the unidirectional movement, right? So if there is defect in that particular thing, this particular syndrome is known as Kartagener syndrome. Kartagener syndrome. Yes, very good, guys. This is known as Kartagener syndrome. Kartagener syndrome. So what is going to be the triad for Kartagener syndrome? Yes. What is going to be the triad for Kartagener syndrome? This is going to be your BDS. B4, there will be bronchiectasis. Bronchiectasis. D4, there will be dextrocardia. What is dextrocardia? Sir, heart will be on the right side. Generally, heart will be present on the left side, because in embryology, what will happen? There will be rotation. If you studied about embryology, what is going to happen? There will be some rotation, and that particular rotation is happening because of the cilia. So if there is ciliary defect, what is going to happen? This rotation is not going to happen. Heart will remain on the right side. S4, there will be sinusitis. S4, there will be sinusitis. Sinusitis, we are having sinuses, they will be having cilia. So when you are driving a bike, what is going to happen? Those dirt particle, whatever foreign bodies that are going inside, what is going to happen? They are going to come out in the form of cough. Now what is happening? Ciliary movement is not there. If ciliary movement is not there, then what is going to happen? All the foreign bodies will be getting accumulated inside those sinuses, paranasal sinuses that you are having, like frontal sinus. So what is going to happen? There will be accumulation of foreign bodies, there will be bacteria coming, there will be pus formation, right? There will be some inflammation, right? So this is sinusitis that is happening because of not motility of the cilia. Third thing, what is going to happen? Every month there will be rupture of ovaries, and because of that, what is going to happen? The ovum will be coming up. So whenever there will be rupture of ovaries, the ovum will be coming up, and this ovum is taken up with the help of these fimbrias. These fimbrias will take up this ovum, and they will be transporting this ovum to the ampulla. There will be the fertilization, right? So if there is no cilia, there will be no transport. There can be infertility, right? This is the patient that we are having. Right? This is the patient that we are having. So there is a patient, 31-year-old patient, trying to conceive, but she is not able to conceive. What is the problem? When we are doing the x-ray, we are finding dextrocardia is there, sir, bronchiectasis is there, we are having problem with the cuff, she is not able to pass the sputum, right? She is also having headache because of sinusitis. So this type of question and this type of patients are also coming to you, right? So you need to understand this is a case of ciliary motility defect, and the answer will be here in this particular scenario will be dynin. Is that okay with you? No issues with this? Give me a quick thumbs up if you guys are understanding. Give me a quick thumbs up. so that I will get to know that you guys are understanding, right? All right. Next question in the list. Next question in the list that we are having. Which of the following junction is helping the cell to bind with the basement membrane? So which of the following junction is helping the cell to bind with the basement membrane? Let me make you understand what are the junctions that we are having. What are the junctions that we are having? Try to answer. Wonderful. I can see. So let me make you understand what are the different junctions that we are having. Guys, we are having skin. Skin will be having different cells. Skin will be having different cells. How these cells are getting coming together? They are attached together with the help of certain junctions, right? All over the body. What we understand with the physiology, simple understanding, everything is all about the cell, right? Cell is the basic structural and functional unit, right? How these two cells are getting connected with each other and connected with the basement membrane, let's try to understand. So some of you are answering already, right? We are having certain junctions. Let me make you understand. So this is a two cell. These are two cells. We are having certain junctions. The first one we are having is tight junction. Second we are having is adherent junction. Then we are having desmosomes. We are having gap junctions. We are also having hemidesmosomes. So let me make you understand. This tight junction is made up of claudin and occludin. This tight junction is made up of claudin and occludin, whereas this adherent junction is made up of cadherins. This is made up of cadherins and actin, right? Desmosomes, suppose this is a keratinocyte, this is another keratinocyte, they are binded together with the help of this particular thing. This is your desmosome. So this is going to be your desmoglein, desmocolin, desmoplakin, plecoglobin. These are your desmosomes. The function will be simple. They are going to bind two cells together. This is what is happening over here. These two cells are binded together with the help of desmosomes in the skin, right? Next one is your gap junctions. Maximum gap junctions you will be finding in your heart, right? In your heart you will be having this gap junctions, and remember this gap junctions are made up of connections. Why gap junctions? Sir, heart will be contracting at a single time, so it will be requiring some type of gap junctions, right? There will be some type of gap junctions they are requiring, so that impulse can transfer from one cell to another very fastly, right? So we are having these gap junctions present in your heart, right? This is going to be connection. And lastly we are having this hemidesmosomes. These are your junctions which are going to bind. Suppose these are two cells, they are binded together to the basement membrane with the help of these hemidesmosomes, right? So the function of hemidesmosomes is to connect these cells to the basement membrane. So this is going to be your basement membrane and these are going to be your cells, right? So they are connected with the help of hemidesmosomes. We are having hemidesmosomal proteins like BPAG1, BPAG2. We will be studying together in dermatology. Like we are having mutation of this desmosomes, there will be a disease. What is going to happen? You will be having these blisters on the body, right? These two cells are binded together. If there is some problem, what is going to happen? These two cells are going to drift apart. These are two cells binded together with the desmosomes. No desmosomes, they will be drifted apart and you will be having this type of formation of bulla, right? This is your pemphigus. Second one we are having is bullous pemphigoid. Now what is going to happen? They are binded together, but problem now they are away from the basement membrane. So you will be having certain space, and in that particular space you will be having accumulation of fluid, and this fluid is known as bullous pemphigoid. This is a clear viscous fluid that we are having, right? So this is going to be the important things. Connection mutation will lead to a special disease that is known as Charcot-Marie tooth disease, right? And this occludin and claudin are present at two places. First one is your blood brain barrier, that is why most of the things cannot pass through, right? This is a tight junction. And second one is your blood testis barriers, which is made by Sertoli cells. So all these things that I'm telling you, they are questions, right? So we are having the answer is hemidesmosome. So which of the following junction helping cells to bind to the basement membrane? If two cells they have asked you, then your answer will be desmosomes. Okay, now try to identify. Given below is the pressure volume graph of cardiac cycle. Identify the point A in the given diagram. What is the point A? So this is your point A. Identify this particular cycle. What is this particular cycle that we are having in front of us? If you understand this, that is great. If you don't understand this, let me give you a quick explanation. I'm going with the basics. So we are having these four chambers in the heart. We are having right atrium, we are having right ventricle, we are having left atrium, we are having left ventricle. The blood will be going away from the left ventricle via aorta, and this blood is going to come back to right atrium via vena cava. And now from here the deoxygenated blood is going to the your lungs. Your lungs will be here, right? And the oxygenated blood is going to come back from the lungs, right? This is the basic story that we are having. We are having tricuspid valve. Three will be first, that is going to be tricuspid. Then we are having bicuspid valve, right? So what is going to happen? Let's assume any point. At point A, what is going to happen? You will be having, suppose you will be having some fluid over here, and at point A, what is going to happen? This valve is going to get closed. This is your mitral valve, this is your bicuspid valve. Now we are having this fluid, and this fluid or this blood needs to transport it to the complete body. This blood needs to get transported to the complete body. इसको पूरी बॉडी में भेजना है. तो फर्स्ट ऑफ ऑल, बिफोर सेंडिंग, व्हाट वी नीड टू डू, हमें प्रेशर बनाना पड़ेगा, बिकॉज वी आर हैविंग दिस left ventricle wall. This is a thick wall, so we need to generate the pressure. And this particular step that we are having, this is known as isovolumic contraction. And the first heart sound that you will be finding over here, this is the first heart sound. And I am assuming I am having 120 ml of blood right now here. I am assuming I am having 120 ml of blood. I am increasing the pressure at the same volume. This is known as isovolumic. Same volume will be there, 120. I am causing the contraction. I am increasing the pressure in the ventricle. This is known as isovolumic contraction. Now, what is going to happen? Now, at a certain point, at a point B, what is going to happen? This aortic valve is going to get open. Now, this aortic valve is going to get open. There will be fluid which will be going out. You will be having rapid ejection. The blood will be going to the body, rapid ejection will be there, there will be slow ejection. So all the blood will be going to the body, right? Because this particular valve is open now, that whatever blood is there, it will be going out to the body. This blood will be utilized, and this blood will be again coming back via vena cava, right? What will happen to this valve? This valve will be opened at point B. Now you will be having rapid ejection, then you will be having slow ejection, and then you will be having a specific step that is known as protodiastole. Protodiastole will be there. And here at this particular point, after from this 120 ml, only 70 ml will be going away. 50 ml will be staying at this particular point. That is what is known as end systolic volume. This is what is known as end systolic volume. This is the 50 ml that is going to stay over here. Now what is going to happen? Here you are having 50 ml of blood. Here you are having 50 ml of blood, and the blood is transported to the body. Now this valve needs to get closed. This valve needs to get closed, and when this valve is closing, you will be hearing another sound that is due to C point. That is going to be your closure of aortic valve. Now this valve needs to close because the blood is already gone. But how much is gone? 70 ml will be gone out of 120, and 50 ml will be here. 50 ml will be residing here itself, right? So what is going to happen? The next step, we are having lots of pressure over here again. The pressure will be sustained, pressure will be there, right? But if I open this valve, what is going to happen? There will be mitral regurgitation. You always study what is mitral regurgitation. There can be mitral stenosis, there can be regurgitation, right? That means the blood from ventricle will be going up, and it should not be there. So first thing what we need to do, we need to do isovolumic relaxation at the same volume. What is the volume? 50 ml. We are going to relax the ventricles, and the pressure, this is a pressure, the pressure will be decreasing, the pressure will be coming to the point 0. Here you will be having 0 pressure, here you will be having 0 pressure. And at this particular point, now what is going to happen? Now I can open this particular valve. Now I can open this valve, and the blood from the left atrium is going to come below. The blood can come from above chambers to the below chambers. Now you will be having rapid filling, you will be having slow filling. And at the point A, what is going to happen? Here should be closure of this particular valve. This is your mitral valve. So the question that they are asking, what is the point A is indicating? The point A is indicating what? The point A is indicating closure of mitral valve, and here you will be having 120 ml of blood. This particular cycle you can divide it into two parts. One is your systole, another one is your diastole part. This one is your systole, this one is your diastole part, because everything that is contracting, depolarizing, systole, all these terms are similar. So what is going to happen? Here we are contracting, here there is ejection, here there is also ejection. So this is a part of systole, and whatever volume that you are having over here after the systole, this is known as end-systolic volume. Okay, this particular part we are relaxing. Relaxation is diastole, relaxation is repolarization, so that is going to be diastole. So what is happening over here? Here we are having decrease in the pressure, right? Isovolumic relaxation, you will be having filling because of gravity, so that is going to be filling because of gravity. So what is going to happen? Whatever blood you are having over here, whatever blood you are having over here, this is going to be your end diastolic volume. This particular cycle is known as diastole. I hope you understand this. If there is an issue, you can ask, right? So this is going to be end diastolic volume. We can also call it preload. Load means contraction. So before load, whatever blood is there, 120 ml, this is known as preload. After the contraction is known as afterload. These terms are important. Afterload means whatever is left after the contraction, that is 50 ml, that is going to be your afterload, that is going to be your 50 ml. If you want to understand what is cardiac output is heart rate into stroke volume. So what is cardiac output? 5 liter will be cardiac output. कितना blood दिल में से बाहर जाता है within a minute, that is going to be your cardiac output, right? So how you can get the cardiac output? You can multiply the heart rate into stroke volume. What is the stroke volume that we are having? Stroke volume is simple. Sir, यहाँ पर 120 था, यहाँ पर 50 है. 70 ml is going out, and that 70 ml is known as stroke volume. So it will be approximately coming out as 5 liter, and this is the graphical representation that is happening within a single cycle of your heart. तो heart एक मिनट के अंदर 72 times beat करता है, let's say. Okay, so if heart is beating 72 times in a minute, so in a single cycle, what is happening? That is what is happening in a single cycle, that is going to be for 0.08 second. This is what is going to happen. Okay, we cannot go into detail, but this is pretty much you should be knowing. At least you should be knowing these markings. This is going to be your isovolumic contraction, your rapid ejection, your slow ejection. Point C will be there, that is going to be opening of the aortic wall, sorry, closing of the aortic wall. Then there will be this isovolumic relaxation, there will be filling, and then there will be point E. Let's say that is going to be your mitral valve will be closed here, right? Mitral valve will be closed here. Simple understanding. Only two sounds that you need to remember. Sound will only come whenever there is closure of the valve. So first sound that you are having S1, it is due to closure of the mitral valve. Second sound that you are getting is S2, that is due to closure of the aortic valve. This is going to give you closure of the mitral valve. Why? Because sir, blood is from above chamber is coming below. Now this valve needs to get closed, and this is going to give you first third sound, that is going to be your lub sound. And then after this whole blood will be going away. Isovolumic contraction, rapid ejection, slow ejection, everything is going out. 50 ml is left. Now sir, this needs to get closed, and if this needs to get closed, this is your aortic valve. This is going to give you which sound? Second heart sound. This is going to be second heart sound that you are going to see, right? So this is going to be the thing, right? Now tell me which is this point A is going to tell you? Closure of mitral valve, closure of mitral valve. Okay, next question we are having, given below is the action potential graph of SA node and ventricle myocytes. Okay, which of the following phase is represented by point A in the graph below? So first of all, let me make you understand. This is a graphical representation of your SA node. SA node का काम क्या होता है? SA node का काम है, it is a pacemaker of the cell. What is the work of the pacemaker? It will be providing the impulse. It is always concerned with the heart rate. Remember, simple fact, always concerned with the heart rate, always concerned. Sometimes they can write you in the question chronotropy. So these two terms you need to remember: chronotropy, heart rate, SA node, simple understanding. Nothing you need to mug up. Okay, AV node, if they talk about, that is going to be always concerned with the conduction, and this particular effect is known as dromotropy. Dromotropy. and muscle is always concerned with the contraction. So this is known as inotropy. These are the three things that you should be remembering, right? Now what is happening within a single second? Let me make you understand. In a single second, this is known as, this is a graphical representation of a pacemaker cell. Within a second, what is going to happen, right? So this is your phase 4. This is known as pre-potential. Why pacemaker is known as pacemaker? The simple understanding, every other cell will be having a resting membrane potential. You always study resting membrane potential is minus 90, minus 70, right? So that is the resting membrane potential. But remember, those cells which are having restless membrane potential, they are known as what? They are known as pacemaker cells. So we are having pacemaker of GIT, that is interstitial cells of Cahal. We are having pacemaker of respiratory system, that is going to be your pre-Botzinger complex. We are having pacemaker of this heart, that is going to be your SA node, right? So what is going to happen, how these things are changing, let me make you understand. So they do not have a fixed potential, they are having restless membrane potential. That means it is oscillating between minus 40 to minus 60 millivolt, right? Now what is going to happen, once it will reach this minus 40 threshold, what is going to happen, there will be action potential, there will be generation of impulse. This phase 0 is going to tell us about the depolarization. Simple understanding that you need to know, depolarization या systole मतलब there will be contraction. Okay, so what are the different things you should be knowing? This phase 4 is because of these important things. First thing is your funny current. Funny current, sodium is a positive charge. So let me make you understand this. First, let me discuss about this so that you can understand that easily. Okay, so how this is a ventricular myocyte. This is a ventricular myocyte. Suppose this is a cell. Let me make you understand how the current is transferring in the body. So these are certain cells. So what is going to happen? This all the cells, you already know all the cells, normally they are present in resting membrane potential. So they are always negative. They are always negative. Normally they are negative. Right now what is going to happen, the sodium is going to come inside. The sodium is a positively charged. When sodium is coming inside, what is going to happen to the negativity? Sir, it will be getting positive, it will be getting positive. So this is the graphical representation. This is your RMP, resting membrane potential. Now what is happening, the sodium is coming inside, and sodium is coming inside. What will happen to the potential? Sir, it will reach up till plus 20. Till the time it will reach up till plus 20, what is going to happen, you will be having opening of certain things. You will be having opening of potassium channels. Now the potassium is a positive charge, it will try to get out from the cell. What is going to happen, the cell is again coming back to the electron negativity. It will try to again coming back to the electron negativity, and this particular phase that we are having, phase 1, is due to potassium efflux. Okay, once it will reach the point 0, what is going to happen, the calcium influx will start. Now the calcium is coming inside and potassium is going outside. Potassium is going outside, calcium is coming inside. That would be making a plateau phase. This is your plateau. Now what is going to happen, you will be having more potassium channels opening, and this potassium will be leaking out. This potassium will be leaking out, again taking back the cell to the resting membrane potential, or again coming back to the normal potential. Once you understand this, it will be very easy for you to understand this. Okay, so this is your earlier, you understand, this cell was electron negative, every cell was electron negative. Now what was happening, this cell is becoming positive. Now this cell will be positive because the sodium will be transferring like that. Now this cell will become positive. What will happen to the backside of the cell, this is going to again become electron negativity. So this is how this impulse is transferring in the body. This is how the current, the contraction is transferring. First, normally every cell should be in the electron negativity. Whenever the positive charge is coming, that means depolarized, that means systole. Now this is going to transfer to further cells. Now this is going to transfer, right? This is how the impulse is being transferred, right? Now we are going to discuss about the pacemaker potential. This pacemaker will be having the same steps, right? How the question they will be asking you, they will be asking you, phase 4 is indicative of what? Phase 4 is telling us about the resting potential. Phase 0 is due to, phase 0 is depolarization, it is due to sodium influx. Phase 1 is due to potassium efflux, potassium is going out. Phase 2 is due to calcium influx. Phase 3 is due to potassium efflux, and phase 4 is due to, again coming back to, resting membrane potential. If you understand this, arrhythmias are very easy for you, because all the drugs, sodium channel blocker, calcium channel blocker, will be working here itself, right? This is how you will be understanding. Second thing, this is your essay note. This is your essay note. So what is going to happen? This is your restless membrane potential. This is your restless membrane potential. Three things you need to understand. We just need to make this cell positive. This is your electron negative cell, which is having restless membrane potential oscillating between -60 to -40 millivolt. So first phase, that is due to funny current. This is a type of sodium channel. These are your sodium. So sodium will be coming inside. It will be making the cell positive. Second thing, that is your T-type calcium channel. T-type calcium channel. Calcium will be coming inside. It is going to make it positive, right? Third thing will be there, decrease in potassium efflux. So the question they will be asking you, pre-potential is due to all these three except. This type of question they are asking. NEET PG previous year question is this: all of the following are the features of phase 4 except. So this can be due to sodium influx, this can be due to T-type calcium influx, this can be due to decrease in potassium efflux, right? So this is going to make it what, till -40. After this, what is going to happen? After this, calcium is going to come inside, and this is going to do the depolarization of the cell, and again repolarization will be same due to potassium efflux. So only step that is different between these two things is your step number 4, and this is the question they are asking. This is the question they are asking: what is the step number A is telling us, right? So in the essay note, this step is telling us about the pre-potential. This step is telling us about the pre-potential, whereas in this particular phase it is known as depolarization. Let me make you understand. So here also phase 0 is depolarization, here also phase 0 is depolarization, here phase 3 is repolarization, here also the phase 3 is repolarization. But what about this phase 4? Here it is resting membrane potential, but here it is what? It is pre-potential. It is pre-potential. That is the only question that can be asked from this particular thing, right? All the courses, this is done and dusted. Very, very important. If you can, you remember, if you want to understand how we can increase or decrease the heart rate, you always study parasympathetic or sympathetic nervous system. Sympathetic will increase the heart rate. Whenever a dog is running behind you, you will be having more heart rate. What is going to happen? Let me make you understand. This slope of pre-potential will be increased because of adrenergic system, because whenever there is a dog running behind you, what is going to happen? The slope will be increased. Now try to understand. If slope will be increased, you will be having this one contraction, you will be having this two contraction within 1 second. You will be having heart rate what? 60 second, you will be having 120 heart rate. Okay, second thing, parasympathetic will decrease the slope of the system. Now you are having just half of the contraction. Okay, you understand where these things are working? Parasympathetic, sympathetic, they are working over here. They are working on the pre-potential. Very, very important thing. Okay, next question. So this is going to be done. Next question, this is your previous year question. Which of the following hormone is coming from the layers shown below in the diagram? Okay, which is the hormone that is coming from this particular layer? Try to answer this one. Which is the hormone that is coming from this particular layer? Adrenaline, you already know. Adrenaline is coming from the adrenal medulla. Adrenal medulla. This is your exam question. ADH, ADH is coming from where? Let's discuss the story of ADH. It is going to come from the hypothalamus. It is going to come from the hypothalamus. It is getting formed in the hypothalamus, but remember, it is getting stored in the posterior pituitary. Very, very important question. Posterior pituitary, it will be stored, not formed in posterior pituitary. Remember, posterior pituitary does not form anything. This hypothalamus is going to make this antidiuretic hormone. It is going to get stored over here, right? Now this is going to get transported to the posterior pituitary for the storage, and now from the posterior pituitary it will be coming out. It will be having certain receptor, V1, V2, V3 receptors. V1 is responsible for vasoconstriction. The drug, if you want to remember, that is terlipressin. It is going to cause what? Vasopressin. ADH is also known as what? Vasopressin. Vasopressin. So it is going to press the vessel. V2 receptors are present in your lower duct of lower part of the nephron, right? No, lower part of the nephron. So that is going to be responsible for the aquaporins, that is going to be present on the aquaporins, and V3 is responsible for the release of ACTH. This is the complete story of ADH. If the levels of ADH are going to low, this is going to cause a disease that is known as diabetes insipidus. If the levels of ADH are going to go high, this is going to cause a disease that is known as SIADH, syndrome of inappropriate antidiuretic hormone, right? For the treatment, this is the drug of choice. It is central and nephrogenic. You will be studying in pharmacology. Central drug of choice will be desmopressin. Nephrogenic, we are giving thiazides, whereas in SIADH, the drug of choice will be conivaptan, tolvaptan. Vaptan is your vasopressor antagonist, right? This is what you will be giving. What about this particular thing, aldosterone? Remember this. This is the cross section that we are having. This is the exact image that you are getting in your examination. So we are having the adrenal gland. Adrenal gland is a suprarenal gland. It is present on the kidney, right? It will be having zona. It will be having three layers. First, it will be having cortex, and then it will be having medulla. It will be having medulla, two parts. One is your cortex, another one is your medulla. In cortex, we are having three layers. First one is your zona glomerulosa. Zona glomerulosa. GFR is the mnemonic. Zona fasciculata. Zona fasciculata. And zona reticularis. Third layer will be zona reticularis. These are the three layers. Apart from that, this particular layer we are having, this is your adrenal medulla. So what are the different things that are coming from glomerulosa? Glomerulosa, remember, it is always concerned with the salt or mineralocorticoid. Okay, fasciculata is concerned with the sweet, pehle salt for sweet, and then it is going to be concerned with the sex, right? And medulla is concerned with the catecholamines. Okay, so what is the salt that we are having? Mineralocorticoid, that is your aldosterone, first important thing. Second sweet we are having is cortisol, steroids. Okay, and this is going to be your dihydroepiandrostenediones. These are your androgens, right? So these are the important things. And this catecholamines will be comprising of what are the catecholamines that we are having? Sir, we are having epinephrine, we are having norepinephrine, we are having dopamine. These are the catecholamines that we are having, right? Where this aldosterone is going to work, this aldosterone is coming from the adrenal medulla. It will be going to the upper part of the collecting duct. It is going to go in the upper part of collecting duct, where we will be having with cells. The complete story I'm telling you. With cells we are having principal cells, intercalated cells. Principals and intercalated cells will be there, right? And it is going to make what? It is going to do, suppose this is your aldosterone. This aldosterone is going to come, it is going to make ENaC channel, and through those ENaC channel, what is going to happen? So sodium will be coming inside, and along with the sodium, water will be coming inside, and along with the water, sodium and water reabsorption will be there. So the function of aldosterone is to do sodium and water reabsorption, and it will be removing what? It will be removing potassium and H plus. It is going to remove what? Potassium. In exchange of sodium, potassium and H plus will be going out. This is the function of aldosterone. Cortisol is an anti-inflammatory thing. It is the steroids that we are having. It is an anti-inflammatory. Whatever steroids that you are studying, they will be having this glucocorticoid functioning, right? So it is going to be an anti-inflammatory thing, right? If there is tumor of adrenal medulla, that is nothing but your pheochromocytoma. So what is going to happen? Pheochromocytoma. These are all sympathetic things, and remember, sympathetic nervous system always increases the heart rate and BP. So what is going to happen? This tumor will also lead to increase in the heart rate and BP. The drug that you are giving is phentolamine or phenoxybenzamine, right? You can study in pharmacology, right? So we are done with this. So this is the question that they have asked you. What is this first layer is indicating? The first layer is indicating what? This is your zona glomerulosa, and it will be releasing what? Aldosterone. It will be releasing what? Aldosterone. I hope these things are clear to you. This is for the revision purpose, right? A 23-year-old female patient is presented to OPD with the symptoms of fatigue. Patient is having what? Fatigue. Patient is having what? Pallor. Patient is having weakness. Patient is having no neurological deficit. Remember, she is not having any neurological deficit. On further examination, koilonychia. What is koilonychia, bache? What is koilonychia? Koilonychia is noted. The doctor has advised the iron therapy. Okay, you get the answers. The doctor has advised the iron therapy. Which of the following enzyme is responsible for the conversion of ferric to ferrous form in duodenal mucosa? Iron absorption, very, very important. Mohammed, you are answering DMT. Yes. Give me more inputs, guys. I want more inputs. So let me make you understand what is this. Let me make you understand this. So whatever iron that you are eating, it is going to come in the form of Fe3 plus. It is going to come in the form of Fe3 plus. Fe3 plus is something that you are eating. Okay, now what is going to happen? This Fe3 is the ferric. You can remember ferric will be having C, so that is going to be Fe3 plus, Fe3 plus, right? So this is the ferric that we are eating. It is going to go from your stomach. It will be going through your mouth. It will be going through your stomach. Now this Fe3 plus needs to get converted into Fe2 plus. And the enzyme that is going to be responsible for this particular thing, this is your gut. Let me make you understand. This is your gut. Here your food is there. This is your duodenal epithelial cells. This is your duodenal epithelial cells, and here you will be having the blood vessel. Here you will be having the blood vessel. You understand? You can orient yourself. This is the compartment. We are having the food. This is your epithelial cells, and this is going to be your blood vessel. Now this Fe3 plus, sir, it cannot get reabsorbed from this particular duodenal cells, right? Absorption of iron is happening at the level of duodenum. So this is not happening, sir, because this particular thing has a specific transporter. Your previous year exam question, this is having a specific transporter that is known as DMT1, right? Divalent metal transport. Divalent means you must have studied about valency. So this is a trivalent thing. This is a divalent. So Fe2 plus can only go through this. So first of all, we need to convert Fe3 plus into Fe2 plus with the help of reductase enzymes, and this is known as duodenal cytochrome B reductase. This is known as duodenal cytochrome B reductase enzyme. So this is what the question examiner is trying to ask. He wants to know ferric to ferrous is happening at the level of duodenal mucosa with the help of what? With the help of duodenal cytochrome B. So this is Fe2 plus. Now this Fe2 plus can go inside with the help of this DMT, right? Either it can go out, either it can get stored. Either it can get stored in the form of iron storage is in the form of ferritin. Iron storage is in the form of ferritin. So either it can get stored in the form of ferritin, either it can go out. It can go out with the help of a thing that is known as ferroportin. And remember what I've told you. So this is the blood vessel. So this Fe2 plus can come out. Now in blood vessel, Fe2 plus is non-utilizable. It requires Fe3 plus. So what we need to do, we need to convert this Fe2 plus into Fe3 plus. And for this particular purpose, we need one more enzyme, and that is going to be your hephaestine. This is going to be your hephaestine. Very, very important iron absorption. Now this Fe3 plus, sir, it cannot transport. It requires Ola Uber, right? It requires cap. So for transport purpose, it is going to bind. What is the transporter for iron? Yes, that is going to be your transferrin. It is going to bind with the transferrin, and now it can go to the bone marrow. Now it can go to the bone marrow for what? For the RBC production, protoporphyrin ring, hemoglobin production, right? So that is going to go to the bone marrow. Second thing, it can go to the liver. It can also go to the liver, right? And in the liver, whenever we assess, whenever we understand that enough amount of iron is there in the blood, this is in the blood. So whenever there is enough amount of iron in the blood, what liver will do? So liver will put a brake. Liver will put a brake, and this is the brake it is going to put. It is going to put a brake on ferroportin, and this brake is known as hepcidin. This brake is known as hepcidin. So it is going to inhibit ferroportin with the help of hepcidin. Now what is going to happen? Whenever this liver will sense that enough amount of iron is there, it is going to release hepcidin, and hepcidin is going to block ferroportin, right? So this is going to be happening, right? If there is mutation, you will be studying in pathology, if there is HFE gene mutation, hepcidin mutation, what is going to happen? This iron will be deposited to different tissues. It will be deposited on the liver. You will be having liver cirrhosis. It will be deposited on the pancreas. You will be having Brown's diabetes. It will be deposited on the bone marrow, on the skin, right? It can cause hemochromatosis, right? So all this thing will be happening because this brake is not functioning, right? So you understand this. This is the basic understanding of the iron transport. Everything is has been asked. This they have asked you, this question they have asked you, this question till now they have asked you, and this question is coming from the pathology, right? Very important thing, right? So you understand what is hepcidin, what is hepcidin, what is DMT, what is duodenal cytochrome B. Your answer in this particular question will be duodenal cytochrome B. Second question they ask about the iron absorption. You understand iron absorption is happening at the level of duodenum, but what are the things that are going to increase the iron absorption? So acid will increase the iron absorption. Remember, be it your ascorbic acid, orange juice, be it your acid, any kind of acid, it is going to increase the iron absorption, whereas alkalis will decrease the iron absorption. Be it your milk, be it your coffee, be it your tea, phytate, oxalates, right? All these things will decrease the iron absorption, right? And remember, the iron is the amount of iron is inversely proportional to TIBC. TIBC you will be studying in pathology, right? So this is what is important for the treatment per se. You will be giving iron in different forms. We are having oral and parenteral. Oral is always preferred over parenteral, but it will be having certain side effects, so we are preferring the oral drugs, right? Those people who are not compliant with the oral, then we will be going for the parenteral one, right? So next question that we are having, given below is the hemoglobin oxygen dissociation graph. Hemoglobin oxygen dissociation graph showing the right shift of the graph. All of the following can be associated with this except. Yes. Yes. Yes, Saloni. Oxalates, phytates. Yes, Rahul. Right, try to solve this one. Given below is the oxygen hemoglobin dissociation graph. Right shift is due to what? Let me make you understand simply. Right shift is due to what? Okay, this right shift and this left shift, they have asked this question multiple times they are asking, and this time you will be marking it right. This time you will be marking it right. So what is going to happen? Let me show you the story. So what is the story? We are having hemoglobin, we are having oxygen, they are a couple, right? So they are connected together with each other and they are a couple. So what is going to happen? They are having high affinity. High affinity means they are binded together. So when this couple is going to get broken, whenever there is decrease in affinity, affinity मतलब क्या होता है? Love होता है, right? So decrease in affinity, decrease in love, what is going to happen? This oxygen is going to get away from the hemoglobin. और oxygen कब get away होगा? Oxygen कब get away होगा? Whenever the tissue requires the oxygen. So whenever there is hypoxic condition, whenever there is hypoxia, so can I call hypoxia मतलब क्या हो गया? Oxygen कम हो गया. That means can I also call it there will be increase in the levels of CO2? Yes, I can call it increase in the levels of CO2. Another thing that you should be remembering throughout your life from now, CO2 बढ़ेगा तो H plus भी बढ़ेगा, दोनों बाई बाई है, right? Both of them are brothers. So you can remember whenever there is rise in CO2, there will be rise in H plus. Okay, like in the cases of diabetic ketoacidosis, what was happening? DKA patient, he will be doing Kussmaul breathing. Kussmaul breathing मतलब fast breathing, right? Rate भी increase होगा, rhythm भी increase होगा. What he is trying to do is trying to get out the CO2. That is what is happening. Acidosis, that is what is happening. Acidosis, whenever there is increased CO2, there will be increase in the levels of H plus, and this increase in level of H plus, can I also call it decrease in the pH? Yes. Can I also call it decrease in the pH? Increase in the H plus, decrease in the pH. This is known as acidosis. This is known as acidosis. This is your acidosis. So whenever there is decrease in affinity, there will be hypoxic condition, there will be increase in CO2, increase in H plus, decrease in pH, also known as acidosis. You understand this? This particular effect is known as Bohr effect. Bohr, you can remember, it will be having R, so this is going to cause the right shift of the graph. This is the right shift of the graph. Whenever there is reduced affinity, other things will be increased, temperature badhega. Okay. uh, because of temperature, what is going to happen? They are going to get breakdown, right? They are going to get breakdown. Whenever there is going to increase in 2-3 dpg and increase in the level of H plus, that is nothing but your acidosis. That is nothing but your acidosis. Okay. Left shift कब देखने को मिलेगा? When you are going to see left shift whenever there is high affinity. अभी क्या हो गया? low पक्का है, right? There is high affinity. हाई एफिनिटी मतलब दोनों साथ में है. साथ में क्यों है? बिकॉज टिश्यूज को रिक्वायरमेंट नहीं है. टिश्यू को रिक्वायरमेंट नहीं है तो आई कैन कॉल इट देर इज इंक्रीज इन द ऑक्सीजन. If there is high oxygen, there will be high affinity. They will not get separated, right? So there will be decrease in the levels of CO2. Decrease in the level of CO2, can I call it decrease in the level of H plus? Decrease in level of H plus is what? Acidosis or alkalosis? This is going to be your alkalosis, and there will be increase in the pH. There will be increase in the pH. This is going to be happening over here, and this particular effect is known as Haldane effect. This particular effect is known as Haldane effect. You can remember L will be there, right? So this is how you can remember, right? So now try to answer. This is right shift of the graph. Right means there will be release. Right means there will be, right shift means there will be release of oxygen. Right shift, release of oxygen. Right shift, release of oxygen. Release of oxygen, right? So this is going to be all except alkalosis. The answer will be here alkalosis. The answer will be alkalosis here, right? Next question. Given below in this particular cystogram, volume of bladder is increasing, but there is not much increase in the pressure. So what is happening? The volume of bladder is increasing, but there is not much increase in pressure. That means they are talking about this particular step, that is 1B. Which of the following property is responsible for this particular thing? Yes, this is your cystometrogram. This is your cystometrogram. This is a graphical representation of your bladder, urinary bladder. Okay, this is the graphical representation of your urinary bladder, and this is showing pressure, intravesicular pressure, and this is the volume. So what are the steps that we are having? Let me make you understand. So stage number 1A. 1A, can you appreciate? We are having this pressure over here. We are having volume over here. So 1A, you will be having filling. Filling of bladder will be seen. Filling of bladder will be seen. Till what time? There will be increase in the pressure. So this is what is happening. There is some filling. There will be increase in the pressure. This particular step is known as step number 1A. Step number 1A. And till what pressure it will be increasing? Till what volume? So it will be increasing up to 50 ml. And the pressure, you can remember the pressure will be 10 mm of H2O. Remember, it is not Hg, it is going to be your 10 mm of H2O. This is the pressure, it will be increasing. After this, there will be the most important step, that is going to be your 1B. Now what is happening, guys? Look, the pressure remains constant. The pressure is around 10. The pressure is remaining constant, and what is happening? The volume is increasing. The volume is increasing here, right? So this is what is because of increase in volume, but pressure remains constant. And this is the question they are asking, why this thing is happening. So your answer, some are answering B, some are saying D. Okay, there are two things that you need to remember. This is due to a specific law, that is going to be your Laplace law. Laplace law. What this Laplace law is going to tell us? It is going to tell the pressure is directly proportional to 2T by R. 2T by R. So what is going to happen whenever there is going to be increase in the tension? Whenever there is going to be increase in the tension, there should be increase in the pressure. So it is a true statement. But there is also decrease in the radius. R is what? Radius. What is going to happen? This suppose this is your bladder. Now normal property of elasticity is what and plasticity is what? Elasticity, you can remember a rubber band, and if I'm stretching a rubber band, what will happen? It will come back to its original position, right? Second thing that you need to remember is plasticity. What is this plasticity? Plasticity means when you are stretching, let's take an example of chewing gum, right? When you are eating a chewing gum, it will show a specific property of plasticity. That means when you stretch it, what will happen? It will not come back to its original position like your elastic rubber. So this particular property, this plasticity property and this Laplace law is responsible for this particular thing. What is going to happen? As soon as the volume is increasing, what will happen to the bladder? It is a plastic organ, so it is not going to put the pressure. It will increase the radius, it will increase in size. So what will happen? The urine will be getting accumulated, it will be getting dilated, it will not put the exact pressure here, right? That is why we are having what? We are having this Laplace law. And then a point will come, then it will not get stretched. This point is known as point number 2. Point number 2, what is going to happen? This phase 2, what is going to happen? There will be tremendous increase in pressure. There will be tremendous increase in pressure is seen. So this tremendous increase in pressure, can you appreciate here? This tremendous increase in pressure will lead to what? Micturition. It will lead to micturition. This patient will be going for urination. So for second question, they ask you the first urge you will be having at around 100 to 200 ml. That would be around 150 ml, let's say. So 150 ml you will be having first urge for passing the urine, and marked sensation or where you cannot stop the urine, that will be your 400 ml. That will be your 400 ml. That is going to be the mark sensation, because what is going to happen now? The pressure is too much, you need to definitely go for urination. This is what is important, right? So this 1b is because of two important laws, two important things. First one is your property of plasticity, and second one is your Laplace law. Those who have studied the Laplace law, they are definitely marking the Laplace law, but this is also concerned with the plasticity, and the best option will be over here, will be option number D. You understand this, right? Try to solve this question. In the given spirogram, the point E is indicating what? In the given spirogram, the point E is indicating what? What is this point E is indicating, guys? Is it a FRC? Is it a RV? Is it a residual volume or something like that? Let me make you understand this, and then I'll give you the mnemonic so that it will be easy for you to see it in the examination. So what is this different things we are having? Normally, let me make you understand, whatever air that I'm taking inside and it will be going out, that is known as tidal volume. So this is going to be your tidal volume. 500 ml will be your tidal volume. Whatever maximum inspiration that I can do, this is known as inspiratory reserve volume. Whatever maximum expiration that I can do, this is known as expiratory reserve volume. And whatever volume is there that cannot be changed, like you are inflating a balloon, that means this particular balloon will always have some amount of air. Have you inflated a balloon? What is going to happen? There will be some air that should be there always. So lungs is like that particular organ, right? So what is going to happen? There will be some volume which is always there, and this is known as residual volume. This is known as residual volume. And remember, we cannot measure the residual volume with the help of this spirometry graph, right? So everything which is having this residual volume, like functional residual capacity or total lung capacity, we need to use some different techniques. Okay, so this is about the volume. So we are having inspiratory reserve volume, we are having tidal volume, we are having expiratory reserve volume. Okay, and we are also having this residual volume. These are the volumes that we are having. Now what is capacity? Remember, whenever I'm mixing a volume with the tidal volume, let's say this is your tidal volume and this is your inspiratory reserve volume. If I'm mixing both of them, it will become what? It will become capacity. It will become inspiratory capacity. This is your inspiratory capacity. I'm losing out the tidal volume along with the expiratory volume. This is going to be your expiratory capacity. So capacity में दोनों का addition हो जाएगा. How to remember? Let me give you the mnemonic. The mnemonic is रेती TVI. So this is how you can remember the values you have to see. So this side you will be having volumes. So we are having residual volume, expiratory reserve volume, tidal volume, inspiratory reserve volume. These are the four volumes. Here we are going to have capacities, total lung capacity, vital capacity, inspiratory capacity, right? How you can remember this? Residual volume and ERV, they are going to make the functional residual capacity, FRC. Second thing, tidal volume plus expiratory volume, sir, it is going to make expiratory capacity, right? This TV and IRV, inspiratory reserve volume, how much you can inspire deeply, that is inspiratory reserve volume. Tidal volume, normal inspiration, right? Both of them are going to make what? Inspiratory capacity. Tidal volume, inspiratory reserve volume, and expiratory, how much you can inspire, how much you can expire maximally, that is going to be your vital capacity. And if you combine all of them, this is going to be your total lung capacity. That is going to be your total lung capacity, right? So this is how you can remember it. This is how you can remember it. Okay, so these are the volumes that we are having over here, right? Guys, let's take a 5 minute of break because my laptop is getting on low battery. Okay, let's take a break for 5 minutes and then we can continue, otherwise it will shut down. Okay. Hey guys, so let's begin. Which of the following receptor mediates the inverse stretch reflex? So what is the stretch reflex? What is inverse stretch reflex? We have discussed in detail, right? So now we will be discussing about how to solve the question. So what is your opinion about this particular question? What do you think? What would be your answer? So is it going to be a Merkel cell or a Meissner corpuscle? These are some receptors that you should be knowing. So I'll just make all the receptor on a single page so that you can easily understand, right? So we are having this Meissner's corpuscle. Remember, they are very, very important. Every year they are asking question based on them. First of all, you need to understand the location. So if I talk about the location, suppose this is your rete this is going to be your epidermis, then you are having basement membrane zone, then you are having dermis, right? So this particular area you will be having Meissner's corpuscle, Meissner's corpuscles, right? So the part of epidermis which is invaginating into dermis, this is known as rete ridges, and here you will be having what? Merkel cell. Here you will be having what? Merkel cells. Two cells in the stratum basal. Merkel cell will be there. Okay, so this is going to be important, right? So first thing that is clear, Meissner's corpuscle are present in this particular area. This is known as dermal papilla, dermal papilla. So Meissner's corpuscle are present in dermis, whereas this uh, Merkel cell, they are present in epidermis. Is that okay? Apart from this, the second question that you need to remember, what is going to be responsible for what kind of response, right? So we are having this Meissner's corpuscle, they are responsible for gentle tap, for the gentle tap, and they are maximally present on the lips as well as in your fingertips and lips. They are the maximally present. Okay, when you talk about the Merkel cell, they are very, very important for reading in the braille reading in the blind people, that is known as braille reading. So they are very sensitive to touch and pressure. They are sensitive to touch and sustained pressure. Okay, so they are having like this type of books which are having ridges over there. So they are very sensitive and they can understand. For example, they need to understand the A, they will be reading like that. Okay, so they will be using for the cases of braille reading. For the cases of braille reading, we are having with cells, Merkel cells will be there. What about the Pepsinian corpuscle and Ruffini's ending? Ruffini's endings, they are maximally present in the joint capsule, right? They are responsible for skin stretch and vibrations. Okay, and this Pacinian corpuscle, they are capsulated, they are responsible for the deep touch and high frequency vibrations. So this is, just go through this one. Okay, next one about the stretch reflex and inverse stretch reflex. This is going to solve you all the questions. Stretch, and this one is your inverse stretch reflex. So in a stretch reflex, whenever we are having like brisk contraction, whenever we are doing like knee jerk, all these things are what? These are your stretch reflex. You will be having exaggerated contraction. Okay, so in stretch reflex, what you need to understand, what are the different things you should be focusing on? You should be focusing, whenever they are asking question on stretch, they will be asking about the length. You should be understanding, whenever they are asking about length, your answer should be stretch. If they ask about tension, your answer should be inverse stretch, right? Here you will be having contraction of the muscle in the stretch reflex, like your knee jerk movement. Okay, the receptor will be muscle spindle. Here the receptor will be Golgi tendon organ. Here you will be having muscle relaxation. Suppose I want to lift 500 kg, I cannot do that. What is going to happen? My muscle will be getting relaxed. That is going to be inverse stretch reflex. Okay, here the fibers, if type 1A and 2 are written, then it will be a stretch reflex. 1B is inverse stretch reflex. Remember, this is bisynaptic this is going to be, inverse is going to be a bisynaptic type of reflex, whereas this is going to be a monosynaptic reflex. Okay, next thing that you need to remember, alpha motor neuron is going to get activated in the stretch reflex, whereas alpha motor neuron is going to get inhibited. Ultimate function, whenever we are talking about stretch, there will be contraction, muscle spindle should be there, contraction should be there, length should be there, and it is a monosynaptic thing. These are the important things. Ultimately, you will be having what? You will be having brisk contraction because of sudden tap on the muscle. We are having hammer, we are doing a knee-jerk test. That is going to be a stretch reflex. Whereas this inverse stretch reflex, we are going to have it as a tension reflex. Ultimate, you will be having what? Relaxation of the muscle. The organ, the receptor will be Golgi tendon organ, and this is a bisynaptic reflex. And ultimate function, it will be relaxation. Alpha motor neuron is going to get inhibited. These are the important points. I hope you will be able to solve most of the question because of them, right? So this is what is important, right? What would be your answer in this particular case? So now they are talking about Golgi tendon organ or muscle spindle. So muscle spindle is stretch reflex, whereas Golgi tendon spindle for stretch. Golgi tendon organ is going to be your answer. It is going to be inverse stretch reflex. Okay. Now the question number 12. Which of the following receptors are present in beta cells for the uptake of glucose, and also identify insulin dependent glut receptor present in the skeletal muscle for glucose uptake? So this is a two question in one question. First of all, tell me what are the receptors present on the beta cells. Gluts are important. They are asking glut receptors. So what are the glut that are going to be present in your beta cells? These are going to be your glut 1 or glut 2. What is the glut that we are having? So you are having only two options. Very, very easy. So let me make you understand what is going to happen. Whatever glucose that you are eating, suppose you are eating rasgulla, what is going to happen with that rasgulla? Let me make you understand. Or what you want to eat? You want to eat gulab jamun or something, right? So you are eating some sweets, or let's say momos. Let's say momos. So you are eating momos, Delhi wale momos, right? Now what is going to happen? Those momos, those people are eating. What is going to happen? They are going to go into their mouth. They're all the, like, your GIT, it will be going to your stomach, it will be coming back to your duodenum. Remember, most of the things are getting reabsorbed in the duodenum itself. Whatever you are eating, you will be getting reabsorbed in the duodenum and jejunum. Whatever you cannot digest, will be thrown to the colon. Colon will be having bacteria. What is the function of those bacteria? Those are the bacteria which are going to do fermentation. Whatever you are not able to digest, those bacteria will be digesting. That is your dustbin, right? So those momos will be having what? Cabbage or pata gobi, right? What is going to happen? It will be going to the bacteria, right? So what is going to happen? This momos, it will be going to your stomach, it will be going to your duodenum. In your duodenum, what is going to happen? Duodenum will be having SGLT1. You already know duodenum will be having SGLT1, and this SGLT1 is going to absorb what? Glucose. It is going to absorb glucose, and now this glucose is present in the blood. Now this glucose is present in the blood, and if glucose is present in the blood, what do we call it? Is beta, that is going to be hyperglycemia. This is called as hyperglycemia, right? This is going to be your hyperglycemia because of these momos. Now what is going to happen? Suppose this is the same blood vessel that we are having. This is the same blood vessel that we are having. I'm just giving you the quick summary. So this is your same blood vessel. It is going to have what? Lots of glucose is there. Lots of glucose is there because of momos or gulab jamun that you are eating. Now this glucose will be going to this beta cell. This is your beta cell. This is your beta cell, and it will be having certain receptor over here. And beta cells, remember, beta is like 2. So that is going to have glut 2. Now this glucose will be coming inside it. This glucose will be having what? It will be having glycolysis, and product will be pyruvate. You will be having 7 ATP formation, right? Because of this ATP formation, what is going to happen? This glucose is coming inside because it is a passive type of transport. Glut and aquaporin, two important things. They are facilitated diffusion. That means they do not require energy. So what is going to happen? This glucose can easily enter into beta cells, and when glucose can enter into beta cells, it can convert into pyruvate. It can make some ATPs, and here you are having a ATP sensitive potassium channel. So whenever there is accumulation of these ATPs, what is going to happen? This channel is going to get closed. And if this channel is going to get closed, what is going to happen? Sorry, this potassium is not leaking out now. Now this potassium will accumulate inside the cell, and if a cell is having positive charge inside, what do we call it? Yes, very good. That is known as depolarization of the cell. And this cell is getting depolarized. Now this cell is coming into systole. This cell is getting depolarized. So what is going to happen? This depolarization, because of this depolarization, what will happen? Sir, calcium will come inside, And if this calcium will come inside, calcium, remember I've told you three functions: vasoconstriction, muscle contraction, and exostasis. Exostasis means exocytosis, sorry. Exocytosis means what? Whatever vesicle is there, it will be going out. And now we are having vesicle of insulin, it will be having amylin, it will be having C peptide. This vesicle will be going out. It is an endocrine gland. Endocrine gland release their substances directly into the blood. So what is going to happen? This is your blood vessel which is having what? This is your blood vessel which is having hyperglycemia, and this is the same blood vessel which is having what now? Now you are having this insulin. This is your insulin that you are having in the blood vessel. Now you are having hyperglycemia, and now you are having insulin. Now the second question that they are asking how this glucose is going to get utilized. So suppose this is a cell that we are having. Blood is a connective tissue. It will be providing connection, it will be doing the transport, right? So what is going to happen? This blood is going to take this glucose here also, and these are your skeletal muscle, these are your skeletal muscle, these are your adipocytes, these are your cardiac muscles, right? So what is going to happen? This insulin is the key. This insulin is the key, and the lock over here is glut4. The lock over here is glut4. So what is going to happen? This insulin will come and it will open the lock, and now whatever extra glucose you are having, it will be going inside. This extra glucose that you are having, it will be coming inside the cell. Skeletal muscle, you are doing exercise, what will happen? Momos will burn, right? Those momos, those glucose will be burned. If you are not doing enough exercise, what is going to happen? This glucose will make a long chain of triglyceride, and this long chain of triglyceride, when binded with the alcohol, is going to make what? It is going to make lipid is going to get stored in the form of what? Adipocytes. So extra calories that you are eating, what is going to happen? You will be having hyperglycemia. Sorry, you will be having adipocytes formation, you will be having fat accumulation, you will be having fat formation because of carbohydrates, right? And here, after this glucose is going inside, what is going to happen? Some amount of glucose will be there, and this is known as normoglycemia. Now the glucose levels will be normal, right? Now the glucose levels will be normal. So what is the complete story? The story is, whenever you are having hyperglycemia, you will be having what? Glut2 activation. Beta cells will be activated, they will be releasing insulin. This insulin will be going to skeletal muscle, and it will be opening the door. Insulin is the key, right? It will be opening the door, and extra glucose will be going inside the cell. This is going to be the treatment, right? So now they are asking about the glucose uptake in the beta cells. Now you already know, in the beta cells you will be having what? Glut2. And second thing, glucose uptake in the skeletal muscle. In the skeletal muscle, in the adipocytes, the glucose uptake is insulin dependent glucose receptors are there. So insulin dependent glucose receptors are glut4. You will be having glut4. So you will be having glut4 over here, and these glut4 are insulin dependent. That means whenever insulin will come, then only they will get opened, right? In certain diseases we are having the problems with that, like we are having PCOD. What is happening in the PCOD? Sir, these are the follicles, they are arranged in the form of a string of pearl. Reason kya hai? What is the problem? The problem, sir, this receptors, this glut4 is not able to open this insulin is not there. There is insulin resistance, and because of that, what is happening, sir? Glucose is not going to get inside. If glucose is not going to get inside, they will not grow in size. If they will not grow in size, they will not ovulate. This is why this PCOD female is also having anovulatory cycles, right? You understand this? I think this much is enough here. So this is going to be the answer number C, Now try to solve this question. A 28-year-old male patient had a road traffic accident, and because of the accident, there are some injuries to which part? Ileum and some part of the jejunum.